sail through effectively the way we're seas.
Right, so let's maybe kick off. So give everyone their time. So yeah, welcome everyone to the SHW Cross Team Seminars. We've got 3 excellent speakers today. Looking forward to the discussions as well. So first up, we've got Donald, and yeah, take it away.
Thank you very much. Everybody, just realised that the casual way I've done the title makes it look as though it's saying who has a traumatic brain injury? This guy, which is as far as I'm aware, not okay. Like the Shaft theme song. Who has a traumatic brain injury? Anyway, hi, how you doing? So my name is Donald, and I'm interested in how do we get from exposures, so genetic, lifestyle, or whatever, to aspects of brain structure and function. So there I am holding a copy of my own brain, to cognitive impairment, particularly in older age. And there's my brain as imaged by the university's very fancy 7T MRI scanner. So traumatic brain injury is relatively well studied in terms of sequelae. You know, we have a good understanding that traumatic brain injury is bad. Recently, we showed that particularly it's associated, for example, with the connective wiring in the brain more than things like structures like the hippocampus. So it's associated with worse cognitive ability and aspects of kind of tractography in the brain. But there are 2 ways to ascertain head injury. There is self-report. So that's when people came in for an assessment, they were asked, have you had any history of head injury? And they said yes or no. And there's also ICD codes. So that's electronic health record linkage to NHS records, whether that's hospital admission or death records and interestingly, they don't really correspond very well at all, which is interesting. But what we saw was that the biggest effects on aspects of brain health were the electronic health records. So just to establish, TBI, bad for the brain, that's not going to blow anyone away terribly. What we tend to look at with TBI is UK Biobank. So if you're not familiar, UK Biobank is around about 500,000 people who attended one of 22 assessment centres across the UK around about 20 years ago now. Subsequently, they have been assessed on all sorts of questionnaires, whether it's mental health, socioeconomic, sleep was a recent one, and they've also got a wide variety of omics, so metabolomics, proteomics, every omic you can possibly think of. But what's particularly interesting for epidemiological stuff is that whilst they have a big battery of assessments at baseline around about 2006, they've been followed up ever since then with NHS linkage. So if something happens to somebody in Biobank, we know about it. So here you've got all this data at the baseline, whether it's psychological data, mental health, sleep, personality, all sorts of things. And then you can look and see what happened to these people across the next sort of 15, 20 years. And that's where our study comes in now. So a couple of years ago, we had a very nice intercalated medical project where a student looked at essentially in a particularly large sample size of 500,000 people, what is the association between TBI and risk of subsequent depression? So the benefit of that study was that most studies in terms of TBI had tended to be quite small and clinical. They tend to be 50 people here, 60 people there who were recruited clinically, whereas this was a general population study. And so we saw that TBI was associated with depression, and that is a nice kind of firming up of what we knew, but it isn't terribly astounding. What was interesting, though, was that people with depression were also completely independently were at high risk of TBI. It was bidirectional association going on. So what we were interested in is, given most studies will look at at groups with a history of TBI versus comparators, how different are they other than common covariates like age and sex? Are there differences before people have a TBI? We know, based on that first paper from the student, that people with TBI have high risk of subsequent depression, but also people with history of depression have high risk of subsequent TBI. So do they differ on other meaningful variables too, prior to TBI? Are there characteristics and socio-demographics which are at higher risk of a subsequent TBI in the next 20 years? So we tested for association between a relatively unscientific handful of psychological and socio-demographic variables and risk of subsequent traumatic brain injury in the next 15 years. And why this is interesting is because we know that there are differences, there are personality differences, cognitive differences, all sorts of individual differences which predict, for example, risk of dementia, risk of premature mortality, quality of life in later life. And what we don't really have is a good understanding of what is the trajectory between fundamental differences between people in terms of personality and cognitive differences and so on, and these later life outcomes. TBI could be one of them. So we found that about 5,000 people over about 14 years of follow-up had a subsequent incident TBI. The biggest associations for a risk of TBI were being male, being a risk taker, and deprivation. So it passes the smell test, I think, some of these findings. There was also some quite interesting and I think intuitive interactions where having a degree was protective of risk of TBI, but only in males, not in females. And when you plot the findings, so this table shows associations adjusted for just age and sex, other than age and sex individually. And so you can see that there's relatively modest hazard ratios, other than some really standout ones, like, for example, being male. But when we put all of these things into one big multivariable model, so you model all these things at the same time, all that actually remained was deprivation, male sex, increased age, higher neuroticism, and self-reported risk-taking. Now, I love this figure. I think it says a huge amount. That what you have here is risk of TBI over about 15 years. And what you can see at the top is the group at the lowest risk are females who do not identify as being a risk taker. And at the very bottom, and then you've got females who do identify as being a risk taker, then males who do not, and then finally the real culprits, males who identify as risk takers have the highest risk of traumatic brain injury, which I think is a nice instance of, like, you would probably guess that before you run a regression, you would probably have a vague idea of this, but it's really not been shown at all. When we looked at how intercorrelated all of these different variables were, we found that basically everything correlated, everything bad correlated to a relatively small or moderate degree, such that an unrotated principal components analysis could explain about 20% of the variance. And so that's things like, do you regularly drink alcohol, reaction time, deprivation, do you identify as a risk taker? So actually a lot of these things in the multivariate model probably became non-significant because they were all really quite moderately correlated in the first place. So people who identify as risk takers, people with worse baseline cognitive health, so things like reaction time and memory, males and people without a degree are at significant risk of a TBI in the next 15 years. However, many of these predictors intercorrelate and their hazard ratios change quite a lot depending what's in the model. So this might be collider bias, that we are controlling for things in a multivariate model where you control for everything in one go, you're pulling out a lot of meaningful variance. So what does it actually mean for public health? Some very quick and perhaps obvious variables are informative regarding future traumatic brain injury risk. Education protects males from TBI risk, but not females. That's quite interesting and one for investigation. The heightened association where more neurotic people are more likely to have a traumatic brain injury, we think might reflect help seeking. So more neurotic people are more likely to actually seek services out if they have an injury. We found quite a lot of mild collinearity. So it might be that people with better memory, better reaction time, take less risk. Maybe they go on to further education. Maybe it influences various aspects of their lifestyle. It's also quite targetable. So I remember this ad from when I was younger. Hope the audio works. Go away, go away, go away. Ooh, I hate these modern mouse pads. Everybody go away. Yep, fine, whatever. This is a really nice ad, I remember. Oh, is it not showing?
No.
Very fancy. But... All right. Oh, of course. Right. Yeah. Cool. So. Right, that's more faff than it's worth. Basically, there was a very nice advert. There was a very nice advert about 20 years ago, which is basically just don't drink too much and fall off scaffolding, please. And what it speaks to, I think, is yeah, because it's funny. I kind of get used to it. So this was a nice advert about 20 years ago, all about how please do not get too drunk and fall off scaffolding. And so essentially what this study shows is that there are very clearly specific populations who are at heightened risk of traumatic brain injury, and therefore a population general approach to lowering traumatic brain injury risk might be less effective than actually targeting what we've shown here, which is essentially just males who identify as risk takers. However, risk taking is slightly vague. So in the past, we have published on how risk-taking has a genetic component, but it's quite an ambiguous thing to ask, and it probably varies by your own personality, whether you consider yourself as a risk-taker. So who thinks skydiving is risky right now? Okay. Who thinks cycling to work is risky? Okay. Is driving risky? Interesting. Exactly. You know, so it's an interestingly vague phenotype. Just is risk taking, or do you consider yourself a risk taker? You know, there are people who spelunk that don't consider it risk taking, but there will be people who do all sorts of things that they do not consider risk taking. So it's an interesting and very vague phenotype, and it's actually incredible, I think, that we see this association despite being a 2-second question, which is pretty vague. Also, we know that similarly, the cognitive data in Biobank is not something that a neuropsychologist would be particularly happy with. It's two or three, not even 5-minute tests. So these are 90-second tests, which are very brief. But the fact that they predict risk of traumatic brain injury quite substantially is actually more impressive, because these are tiny, tiny tests, which really are not as precise as a neuropsychologist might like. Some limitations are we know that there's probably a bias in UK Biobank not having enough ascertainment for people with traumatic brain injury. We know that people with traumatic brain injury don't participate in research enough. We had this finding, which I personally quite enjoyed a couple of years ago, where basically what we showed was that people with traumatic brain injury, amongst various conditions, are less likely to attend a biobank imaging assessment, which was about 10 years after baseline. So they're less likely to attend, and then they're less likely to have usable data for researchers at the end, and that's probably because they move too much. So not only are they less likely to participate, they're less likely to attend the subsequent assessments, and they're less likely to have usable data that researchers can investigate. So really kind of, it's a population who are not accurately represented in clinical research. Going forward, ideally, we would love more data to understand the exact pathway between these psychological differences and socio-demographic differences in risk of TBI. So what is it that these people are actually doing that is that's actually contributing to this TBI risk? So a few years ago, for example, we showed that people in Biobank who cycle to work have low risk of heart disease and cancer and all sorts of things, but they're also quite a lot more likely to get whacked by a car. So it might be that there's something there that maybe are they skydiving? Are they cycling? What is it that's contributing to this pathway from psychological differences between people and risk of traumatic brain injury? So a very rapid take home. Head injury is associated with poor cognitive, psychological, and structural brain health. That's not outstanding. But what's more novel here is that it's a predictor, but it's also an outcome of individual differences in the first place. Studies which compare TBI populations versus comparators are probably not comparing otherwise like for like groups. So the TBI and control groups probably differed on psychological variables to begin with, to some extent. There's a pretty clear route to specific public health targeting in this. So it suggests that focusing on a population broad approach will be losing quite a bit of specificity. So if we focus on specific groups, there's probably more that could be done. Thank you very much. And this is a part of a preprint and paper which was led by a couple of intercalated students in the last couple of years. So thank you very much.
Thanks very much. That was excellent. Any questions? Yeah, Hamish.
Hi, thank you very much. So I was interested in your survival curve where you had male and female risk taker, non-taker. Notice of the deprivation. Also, but you didn't have a separate one.
Yeah.
The six groups with deprived, not deprived. I was wondering why you do that.
Yeah, we could do it for deprivation. It's really just that was really just illustrative, that one, just to show that you know, sex and a 2-second question of you know, a hand can illustrate quite a lot of risk of TBI. So there's no specific scientific reason for just sex and risk taking in that particular figure. It just is evocative.
Yeah.
Just on your risk-taking question, I guess perhaps you're saying it's interesting how it's such a vague notion, and we all have pretty poor ideas of the risks of skydiving versus cycling to work. But that's not really what the question is asking, right? It's asking, relative to your peers, do you perceive yourself as being riskier? And probably people have a much finer attuned sense of how they compare to peers than they do to what the odds are of your parachute ride.
Yeah, exactly. So there's a relativity to the question and a subjective nature to it. Yeah, so there's absolutely, yeah. And I mean, so I've always wanted to like drill down into it more, where it's like, does your perception of your risk taking vary by, as you say, demographics or age or sex or even cognitive differences? So do brighter people estimate their risk taking better, for example? So yeah, there's so many ways you could do it and stratify it. Like it.
Petra.
I know nothing about the subject area, so it might be inherently a completely stupid question, but because the UK Biobank has got such poor representativeness, if you then conclude that there is a particular group of people that you should be targeting with preventative interventions, is there a risk that because not all groups are covered? I mean, I'm just thinking for women, probably one of the main risks for traumatic brain injury could be something around domestic violence.
Yeah,
those people will never be in something like the biobank, which requires a lot of healthcare use in those areas. Those populations, then, if you use something like the UK biobank, wouldn't appear, and you might, so the preventative conclusions you draw from studies based on that could then completely exclude.
Definitely, yeah. So I think with biobank, a lot of the time often the conclusion you come to might be right, but it's probably underestimating the scale of things to a certain extent. So, for example, you know, in this we looked at, as you say, there are a lot of people who aren't in biobank. We looked at, you know, males who are risk takers, that the minimum age was 40. So if you imagine, and you know, we saw a modest effect of alcohol, but like if you take these findings, like what will male risk takers who drink too much look like at 18, not 40? So yeah, whatever we find in this kind of stuff is always going to be a massive underestimate of all the things that are going on. Yeah, definitely.
Thanks, Donald. Sort of similar question to Petra, but just thinking about the ascertainment of traumatic injury. I wasn't clear about how that's actually ascertained. Is that on an ICD thing called?
Yeah.
Yeah, and so I'm wondering if women particularly are less likely to have a CT scan if they're in a car accident than men, or if they're in a scenario, or workplace injuries, and that might be due to underestimating.
It's there's also because we don't have primary care data in this, there's probably all sorts of things like, are there differences in personality with who goes to the doctor? Is it that more conscientious people they'll maybe go to their GP in a week?
Workplace, if you fall off the building, your employer's going to send you to the hospital.
So I think with all this stuff, I think it's probably in the real world, it's probably 10 times more exaggerated than the hazard ratios and so on that we're seeing. And it's kind of anything we show is kind of a modest representation of what's probably really going on.
Just last one before we move on. There's one in the chat there about you mentioned possible association around help seeking. Any thoughts around lack of help provision?
So what we were suggesting was that it might be that more neurotic people are more likely. The reason that there is an association between neuroticism and heightened risk of TBI is not necessarily that more neurotic people are more likely to in truth have a TBI, but rather than just that they are more likely to be accurately represented because people who are more neurotic and perhaps more conscientious are more likely, on average, to seek services and be represented in the data, rather than it being a truly causal association where more neurotic people are more likely to have a TBI.
Brilliant. Thanks very much. We have Petra. Lights up.
Yeah.
Should.
Yeah,
no worries. There's a clicker there as well if you prefer.
Good. All right. I thought, well, I've talked to you or lots of people in SHW about the half of my job that's classical changing futures, but not very much about sort of the actual research that I do. One thing I thought I was interesting in is sort of to look at pathways for getting evidence into policy across a number of different projects, and for the last couple of decades, 3 decades almost, running research that is quite policy applied, and sort of see what can we learn from some of these. So practical examples from 3 research consortia, and special thanks goes to Alice, who's helped me put together the slides because I ran out of time. So if I look sort of a bit confused, it's because I'm not as on top of the presentation as I would usually like to be. But so first example case was work around global alcohol policy, or rather actually national alcohol policy, but with global implications. And that came about because I was a new lecturer just out of my PhD, starting out at Sheffield University, thinking, oh, well, what am I going to do with the rest of my career? And I thought alcohol policy might be a good place. And the Department of Health in England was commissioning a review of the relationship between alcohol consumption, pricing, and promotion of alcohol. We told them, well, basically, it's very nice that you want to commission a review, but someone's literally just published a meta-analysis. Do you really want us to do that? Or would you rather have a model of what policy could do for you? And I said, well, actually, we don't care because we've committed in our strategy to spend some money on a review. What do you actually do with that money? There's no plans around alcohol policy in England, but just propose something, have the money, and do what you want. And we use that to build the starting point of a policy model to look at, well, if you were doing something around pricing, or if you were doing something about marketing, what would the health implications be? What would the revenue implications be for government? And that was quite useful as pilot work, because that allowed me to then get quite a substantial MRC ESRC grant a couple of years later, which allowed me to establish a new research group, which then grew over a couple of decades into sort of a group of 30 people, all doing research around alcohol, then tobacco, now gambling in Sheffield. So it's I had no hope that this was going to lead anywhere. Department of Health said, we're not actually that interested in what you find, but giving us money anyway, which was useful. And then the interest came a little bit later. And the first version of that policy model focused on pricing and promotion policies, including minimum unit pricing, which was in discussion in England, but then very quickly got shot down. But Scottish politicians sort of thought, well, we can't do alcohol taxation, but we could potentially do minimum unit pricing, and that is because taxation is not a devolved matter, but minimum pricing doesn't count as taxation. So Scottish politicians saw an opportunity. So we ended up working a lot with Scottish Parliament around minimum unit pricing and produced the model results that helped them through the legal challenges by industry, who said, well, is this a targeted? Could you achieve the same results with a policy that's already in existence rather than creating something completely new? How is it going to affect low-income families and so on? And we sort of were in a dialogue between the evidence needs and the politics around that, so that what we were able to produce always sort of was in tandem with the questions. When there were questions around proportionality, we were able to show, well, this is what you could achieve with tax, this is what you could achieve with minimum pricing. That was then really central for the European court case. So I guess what I'm saying here is, one, start doing the things you're interested in, whether or not there's politics, but then work really closely with people who've got an interest in doing something in the area that you're working in, if you're thinking about that evidence pipeline, and make sure that whatever evidence you produce answers the question that is at the forefront of everybody's mind a little bit. And then, it kept developing and started to influence policy elsewhere. We adapted it to other contexts. In Canada, we've now got a minimum unit price. In South Africa, they were discussing whether or not they wanted one, and decided to do something different on the basis of model results that told them, actually, there you can achieve more with a different kind of policy. We had a lot of conversations with countries that have got an alcohol monopoly around what would happen if they moved to a more tax-based policy structure, and could show that actually having a monopoly is something that gives you full control over the alcohol market, whereas if you only have taxation as a lever, that doesn't. So, something that started very much as a Scotland and England focused thing, then started to have quite a lot of legs, moving out from a Scottish application to a UK application, a data infrastructure that then made it possible to run other things, and then with having quite a bit of international reach. So the second use case is sort of CIPHER, the big systems science in public health consortium. Can't remember what it was a good acronym. I can't remember what it stood for, even though I was the PI for 5 years. But basically that developed tools and models to support policymakers evaluating the health and equity impact of economic and social policies in the areas of housing, in the areas of income, in the areas of work and workplace, focused on embedding systems modeling in government decision making, in priority areas around inclusive. Started out as inclusive economic growth, which then soon got taken over by inclusive economies, or inclusive well-being economies, or well-being economies. So the how people talked about inclusive economies changed over the course of a long-term engagement of 7 years. So it was, I think, really important to keep moving with the language and keep talking the language that our policy makers were. So here in Scotland, it was about wellbeing economy. In Westminster, if you talk about wellbeing economy, you're out of the door before you even get to knock on, because they're all about growth. And if you want to have anything about inclusion, you need to call it inclusive growth, no matter whether you think that growth is a thing that should be pursued or not. So it's kind of the adapting to the policy context and talking to the people in there, and then trying to shift it in the way that you can during the conversation, and get yourself invited first. So policy impacts there were sort of trying to reach into our policy partner organisations. We were working with Greater Manchester and Glasgow City Region and Scottish and Welsh government analysts, basically creating some tools and methods that can now be used in those policy organisations, whether that is, for example, a synthetic population of the UK population which overcomes some of the issues of not having everybody in things like Understanding Society, the big surveys, which are large, but don't have everybody in there, or the census, which got everybody in there, but hasn't got the detailed variables that we need. And what if you model it together, create a synthetic population and make that available to government analysts to use to start to think about, okay, where are vulnerabilities, where is there, what are the health outcomes in certain areas or in certain populations, what are the equity impacts of changing things around, and making those tools available. So that then allows sort of a second-hand use of our tools where we're not the drivers of the model, but people in our partner organizations were able then to use the tools themselves. And that's been partially successful, partially not successful, mainly because of technical capabilities. And that's not the capabilities of the analysts, but capabilities of the organizations. We've been trying for the best part of 2 years to get R to run on government computers. That is just not a thing. You know, you learn what is and isn't possible, but there are things that mean that some things have to be done in a university, some things can be handed over to others. And sort of the way we've been able to influence policy in these kind of projects is more around looking at what statutory frameworks, what policies are coming up, what strategies are being refreshed, and what are the evidence needs for those policies. So when there is a new local economic growth strategy, how can we get some health equity concerns in that by showing, well, if you do this, what's likely to happen is that. But if you did that instead, then you can still get your economic outcomes, but you can also make the world a slightly fairer place. So those kind of conversations, and we've done that across a number of different sort of strategies that have been under development over the last few years. I think sort of key there is co-production, stuff around, I always now put policy partners as co-investigators on the grant if I can. Not all funders allow it, but it's becoming much more acceptable to do that, so that they're actually co-responsible for the project. Focus on policy partners' priorities from the start. Embedded researchers, so I always fund researchers in the policy organizations from within our grant, and that really helps because you've got someone on the ground who keeps abreast of how policy conversations are moving behind closed doors. And also having community voices in, massively important, not the focus here, but having that reality check of whether the policies we're talking about are likely to actually work in practice. Really important, and sort of seeing grants as a knowledge network where you connect partner knowledge and their analysis and their appraisal of the situation with what we would probably consider the formal knowledge of our evidence base. So, so if this is a sort of ongoing research pathways, I've talked to you previously about Health Mod, which is specifically about policy modelling for health, current work around economic determinants of health and wealth inequalities and so on. Again, co-produced by policy partners, this lot. And just transition, and I'm probably not going to say very much about that, but Gallant is a project on climate resilience in Glasgow, and how do you move a whole city towards a sustainable future. And what am I doing in there as a health person? Well, health and systems and everything, sort of, you can't have a healthy future without a sustainable future, and you can't have a sustainable future without thinking about health and equity, because otherwise, things are not moving towards an overall well-being framework. So we're working with donut economics as a framework to think about how do you multi-solve between health and climate and equity concerns, and how do you make sure people have their social foundations and their social needs met whilst also respecting their planetary boundaries. I'm thinking with the government around, well, how do we do that in economic strategy, in our climate adaptation plan, in our circular economy framework that's just been refreshed and so on. And again, us as the evidence providers as one of the partners around the table there. Skipping ahead, so key learnings, co-production right from the start, try to involve people, try to understand what the likely evidence needs are going to be so you can respond to those as things move. Adaptation, things change, you know, Cypher had 5 prime ministers, had Brexit, those afterwards, it had COVID hitting halfway through, the policy landscape completely radically changed. And we just had to say to the funders, well, we won't do what we said initially because that would not be relevant, and they were quite happy for us to tell. So staying flexible enough, and then the timing, being able to do the right analysis at the right time, important. So that's me. Whistle stop tour through policy impact.
Brilliant. Thanks very much. Any questions at all? Yeah.
Yeah, that's really interesting. I was just wondering, because you talked a lot about partnership and getting everyone around the table, I guess. Do you have any insights about getting industry on board with their competing interests?
Most difficult, in my experience, from a public health perspective, and it depends what industry. So relatively easy to get on Gallant, for example, people who are in green energy or, you know, who are sort of quite aligned, much more difficult to get industries that have something to lose. So, I mean, I wouldn't want to get the alcohol industry anywhere near the table of discussing alcohol policy, and actively we've been trying to keep them out and raise awareness of commercial determinants of health and the way that the alcohol industry actors have been playing with the evidence to use it against basically any strengthening of policy. So one, you know, do we want to have industry around the table, and if so, which industry, and is there good industry and bad industry? I think it works where there's a win-win. So, you know, if you've got people who are wanting to sell you some smart data, we've worked a lot with Kantar as a data provider, and you've got to be really careful about the ethics of that. You know, how do you access the data and how do you make it available and how can you use it? Is that still something you're happy with? But, you know, where there's joint venture, joint purpose, then it works really well. But on the whole, if it's something where the commercial actors have got a vested interest in the opposite of what you're trying to do, then I would say we just need to be really careful. And unfortunately, both in the alcohol space and in the economy space, because economic growth, you know, big business or whatever does not usually lend itself to wealth redistribution or those kind of things. And in green policy, even worse, there's a lot of people who have very vested interest in keeping fossil fuels up at the forefront, and yeah, so hesitation around industry probably. So
following on from that, I guess it's quite clear cut with some industries, but when you talk about co-production and embedding researchers within policy teams and having policymakers as co-investigators, how do you manage the inherent biases? You know, people are coming with policies that they want to find the evidence for, and then you're asking them to be a partner in impartially producing evidence that might shoot down the policy they've been elected on or that they're employed to deliver on.
So I guess for me, policy partners, they come in sort of two forms. There is the elected members, so parliamentarians and so on, and then there's sort of the civil service analytic arms and so on. We tend to work more with the latter. Doesn't negate any of this, but it's maybe one step removed from the political masters directly. But I mean, I've had that, and I've learned the hard way that you've got to put your collaboration agreements in place really carefully that protect academic freedom and make sure this is a research-led piece of work where you will publish the findings, whatever the findings are. Yes, you're looking at certain policies. It doesn't stop you from also looking at other policies and seeing, well, you know, this is the thing that you're particularly interested in, what it could do. Just for the record, here are all the other things you could also do. You know what I mean? And that needs to be understood from the start. So I think we have established trusted relationship with a lot of the policy partners we're working with, and they know that that is what is going to happen, and they're happy with that to a degree. But you know, it comes up in terms of learning the hard way. We ran a project commissioned by the Home Office, who then completely stopped any publications around minimum pricing and crime, which is why there is no publications, no whatever, because the research was funded by Home Office, and the Home Office said, no, we do not want you to put the evidence out there. And that was at the start of my career, when I didn't know you had to make sure that your team's protected from those kind of things. Yeah, make sure you've got really good legal advice when you set up agreements with partners.
Brilliant. Thanks so much, Catriona.
Yes.
And last but not least, we've got Catriona.
Yeah, hi everyone, my name's Kat. Thank you for having me along. So I'm gonna pivot to some qualitative work and talk about one of the projects from my PhD, which was trying to better understand sleep health and try and improve sleep among adolescents. So we know that there is a recession in sleep, and that over the past 2 decades, there's been worsening trends among adolescent sleep health, and this has really become a bit of a public health concern. So for healthy development, adolescents need between 8 to 10 hours of sleep, but a study across 24 countries found that less than 50% were actually achieving this on a school night. And we know that this is essential because sleep contributes to not only academic performance and school attendance, but development and increased risk of mental and physical health conditions like cardiovascular disease and type 2 diabetes. But if anyone's got teens in the room, this might be relevant to you, or if you remember being a teen not that long ago. It's a really unique time for sleep, and that's because of this perfect storm model, where during adolescence we go through a physiological change in our sleep onset to being a couple hours later. And this is actually due to a lot of hormonal changes, namely the release of melatonin that helps us get to sleep, being pushed back. And this, combined with the need to get up early for school, really limits your opportunity for sufficient sleep, which is then further compounded by things like peer pressure, school pressures, family life, and everything else that goes on in a teenager's life. Despite all of this, sleep remains largely absent from the public health agenda. So yeah, why have we not really been tackling sleep as much as we need to? First, there's been a real lack of stakeholder engagement. The interventions that are scalable, like sleep education, have not been implemented to the best of their ability. So, you know, they've either not been effective, or typically they're described as boring. So for that, we're taking a community-based participatory research approach to really try and embed co-production and stakeholder perspectives in the design of an intervention. Secondly, is this failure to consider broader factors impacting sleep. So yeah, there are a lot of interventions available, particularly cognitive behavioural therapy for insomnia, which is the first-line treatment for insomnia, but that is very individually focused and not very scalable. So what we want to do is try and look at these broader determinants of sleep health, and to do so, we're taking this socio-ecological lens as well as a multi-level approach, so that we're not just targeting the individual, but considering the broader factors. You're probably familiar with this model, which looks at individual, social and societal issues, and it's been applied to a lot of health behaviours. But more recently in the field of sleep, you can see that Gradner in 2019 actually wrote a book chapter on the socio-ecological model, but since then there's not really been much evaluation for this lens. That's where my research comes in. And just broadly, the PhD overall aimed to co-develop a multi-level intervention using a socio-ecological approach to improve sleep and wellbeing in adolescents in Scotland. Probably a bit ambitious, given that we're not going to have a lovely packaged intervention in the next 6 months or so. But I followed this 6 squid model, as well as the sort of MRC framework on complex interventions, to really try and define and understand the problem and causes in the Scottish context, try and see what factors would be malleable and how we could deliver those change mechanisms. So before I started, I did a bit of a stakeholder consultation just to really scope the problem and understand what it looks like in Scotland. And then I conducted a systematic review of interventions delivered across the socio-ecological model. You might be shocked to find that about 70% of them were at the individual level. So there's a huge gap for family-based, school-based and policy-based interventions. Study 2 that I'll talk about today was looking at a qualitative exploration of barriers, facilitators and opportunities. And then study 3, which is going on right now, is just a couple of workshops to try and sort of tighten up some of these recommendations and ways forward. So the aim of this study was to use a method called photovoice, as well as qualitative interviews and focus groups to understand stakeholder perspectives on sleep. So this was first, what are the barriers and facilitators? And then secondly, what are the potential intervention targets and strategies for the intervention? So we worked with 3 schools across Scotland, all from different socioeconomic backgrounds. And this included 42 teens from S1 through to S3, 15 parents and 14 teachers. And in Scotland, just to point out, there's been a few studies that have looked at adolescent perspectives. I think there was one on parents at the time and no one had considered teachers. So we're really getting a fuller picture. And there is this bit of sort of tension between those 3 groups. So that was really helpful. At this point, you might be wondering, what is photovoice? So yeah, just take a minute to think about what this image represents to you. Some people, it might be, community, connection, maybe business, entertainment. Other people, it's addiction, problems, peer pressure. So the idea behind using photovoice is it really does speak 1,000 words, and there's lots of different interpretations as well as discussions you can get from using this kind of method. But it was developed in the 90s by Wang and Burris, and it was really designed to give voice to marginalised groups, and it's very rooted in feminist theory. And it's since then evolved into a community-based participatory research approach that is used to inquire and solve health problems collaboratively with individuals in their community. So why would we use it in this study? Well, first of all, when I started my PhD and I was starting to use this socio-ecological model, I kind of struggled to think, where does everything fit in? How do you get your head around it? And I thought, how can we expect an 11-year-old to do this? Saying that, they're probably a lot more articulate than me with these things. But we used the photos as a tool to help them with their discussion and thinking about sleep beyond themselves to consider the social and societal impacts. Also, with adolescent research, it is an adult-dominated world, so we use the photos as a way to give voice and platform to young people about their own health and health decisions. And then finally, the photos, as well as the exhibitions we went on to do, were used to kind of bridge the communication between young people and the adults in their life on a topic that is quite, there is a lot of friction, whether it is, discussions around bedtimes or for parents kind of choosing what hill are you going to die on. Is sleep really the priority? So lots came out of that. So I'm going to focus a bit more on the sort of procedures and methods and discussion rather than results. But the study took a whole year, and we first went into schools to do recruitment, which wasn't as successful as we hoped. Initially, we worked with some PSE classes to deliver a sleep education lesson, get everyone excited about sleep, and then they would sign up and take part in the study. That didn't happen. So we expanded and we went to assemblies to have a bigger reach, and we also sent out a recruitment video to parents. So we did get there in the end, but sleep's not always the most trendy topic. So from there, the students that did take part obviously got consent from them and their parents, but then they participated in the photovoice activities, which was a training workshop. And then they went away and they did their photo diaries. And then we had a one-to-one photo elicitation interview. And then they did a participatory analysis where they got all the photos printed out and all the students came together and grouped them into themes, labelled the themes, and sort of made a description that I actually then used in my analysis as my sort of initial framework. Students then chose their favourite photo and wrote a story to go alongside this and designed an exhibition in their school that they then invited friends and family onto. And one of the schools that we really engaged, we had a really successful exhibition where the young people actually presented the findings to about 100 people who came along. And they love that, just having that adolescent perspective and being able to tell their parents what's what. And then in the other two schools that took part, we actually ended up adding the exhibition onto existing events, so like parents' evenings or other things that were going on in the school, because it really depended on the sort of teacher input and capacity. We then used this opportunity to recruit parents and teachers for focus groups. And finally, we disseminated the findings. So you might have seen we had the exhibition in the Clares Peer Hub, which had a lot of interaction. We joined other community events, and we also produced a school report. We actually got some of the IE grant funding to have the participants come back into the university to see their work presented, and we would have like a bit of a development day, so some sleep workshops, and then they could get to see the uni and whatnot. But unfortunately, one of the schools who was really keen, they actually couldn't get the staff cover to get the kids out of the school, which I have since learned is a huge issue, that children can't get out of schools to do these sort of things. The other school who was really keen and we were going to pay for their travel, only 2 of the 12 participants actually wanted to come. And then the third school didn't get back to me. So whilst I thought this was a lovely, albeit slightly stressful study, yeah, there's lots of other barriers in the way. So I won't go too much into the results theme by theme, but I just wanted to point out an example theme that we came up with was this idea that social media is actually a double-edged sword. So we see data of young people are spending 12 hours a day on their phone, and this is negatively impacting their life. Whilst that is true, screens are everywhere, and young people really highlighted the multifaceted use of them. So yes, there is this like bombardment of notifications and peers and everything that tech companies have designed. But there's also sort of more positive uses of social devices. So maybe listen to an audiobook or watching a YouTube video to wind down before bed, as well as the application in schools. And some young people actually reported about school notifications coming in before they're going to bed. So that is a wider sort of policy issue that we could be looking at in the school setting. But just to highlight, and this is just from the young people so far, because we're still to analyse the rest of the parent and teacher data, some of the intervention strategies that have been identified already. So young people acknowledge that, yes, we need more education around sleep, and they actually were interested in learning about it, particularly when it applied to their life. So if you had a young person who, say, is particularly sporty, there's lots of hooks there that you can apply to them and sort of tailor these approaches. They were keen on digital interventions to have a more personalised approach, and most students have a phone, so they were really keen to use that. At the more family-based level, young people acknowledged that their parents didn't necessarily have the answer. One student noted that they have insomnia and they would go down to their parents and say, I don't know what to do, and the parent didn't have any solutions, so they found that really frustrating. So kind of upskilling parents as well as peer education, they're at that age where they don't want to take instruction from their parents, carers or teachers. So having that influence there. And then they really recognise that we can leverage social media and those influencers. So a lot of young people actually get their healthy lifestyle habits from social media. So there is a positive there. In the school setting, education and campaigns, but also screening for problems and upskilling teachers or support staff to have the skills and capacity to actually treat and support any sleep issues. And then really interestingly, young people were quite tuned into the more public health side of things. So they reference things like the 5-a-day campaign or doing 10,000 steps a day as kind of arbitrary policy, but saying, why don't we have something like that for sleep? Why don't we have adverts or posters around? And then of course, in the school setting, they pointed out things like, why are we scheduling double maths first thing on a Monday morning when kids haven't been able to get to sleep till about 3 a.m? The same as, why are we doing exams first thing in the morning when this is a really important and stressful time for young people? So just really briefly, some key reflections. Using this method and working within school context did come with a lot of challenges. And this idea that photovoice is sort of rooted in empowering young people and giving them decision-making and autonomy wasn't always possible in the context of research in the school. that was quite challenging. But with that, there were a lot of positives. It was a really valuable tool for engaging the community, not just the people in the study, but it went far beyond. And it's developed my skills as a researcher to be much more reflective and consider sort of these challenges in terms of power imbalances and the availability of guidance. So if anybody is interested in using photovoice or participatory methods, this is under review in a paper. So hopefully there'll be some nice guidance out there for everyone else to use. And just to highlight briefly how this did go beyond the study alone. So we obviously had the exhibition, but then that since turned into arts-based workshops, community days, and then the learnings from that study have been put into an initial sort of training manual that's been delivered to about 300 different stakeholders, from parents, teachers, and community staff. And although that's not the final intervention, it's a kind of iterative development, because there is a real call and cry out from the community for training and support with sleep. But yeah, thanks for listening. If anybody wants to look at the stories, you can scan the QR code.
That's excellent and really interesting hearing about the methods and process there. Any questions? Yeah.
I found really good from a 13-year-old boy is like exactly correct. But I wonder, so the intervention bit of this really interesting to me, because you often see this the longer you go in public health. We must design an intervention, and there's a lot of noise about it, comes in, and then maybe a few years later we realize probably do more harm than we might be doing. So I don't know if you've explored potential harms of interventions, and particularly when we're thinking about social media-based things or peer group things, and the sleep is so caught up in young people's identity. Right? Anyway, I'm sure you thought very carefully about this, but like, what are the potential harms in it?
Yeah, I think if I could go back in time, because I started so broad to narrow, but that was the intention, and I'm still so broad, and there's going to be about 20 different intervention options, and obviously they overlap. And the workshops that we're running now, we're going to take the sort of main ones, so like school-based, peer-based, family-based, whatever it might be, and just dig a bit deeper and see what are the barriers, facilitators, who could deliver it, and unintended consequences are going to be a part of that. So it's not explicitly came out in the data yet. But yeah, there definitely has been things that we should be aware of. And I think because we're not at that stage, we're still in a position to get ahead of any challenges. So I'll definitely bear that in mind.
So following from that, I wondered, really interesting stuff, whether you're familiar with the idea of insomnia identity. I don't know whether it's from current, there was a review in 2017 about the fact that people with a self-perception that they have poor sleep quality, more predictive of daytime impairment levels in this view than actual level of sleep. So there's something about worrying and ruminating upon sleep quality that can be disruptive. I guess just being mindful of raising salience of sleep being an issue, balancing, so it doesn't become a concern, but then it comes to the problem.
Yeah, no, definitely. It's a huge issue, and that, as they were saying, would be a clear follow-on of potential damage. And not something I've considered right now, but kind of beyond PhD thoughts, is acceptance and commitment therapy is becoming more and more popular in sleep because of exactly what you're saying. That if you have a smartwatch and you're told your data and how poorly you slept, you actually will feel worse that day. So something around this sort of worry and anxiety is definitely scope for. And I think ACT is a really good example of something that's easily scalable compared to CBT that's maybe a bit more involved and needs to be a bit more sort of, I don't want to say clinical, but procedure based.
I think we're out of time, unfortunately. Hey, much if you could catch after, but thanks so much, Kat. That was excellent. And thanks all speakers. So that's the last one before Christmas. So enjoy your break all when it comes, and we'll see you again in February. Thanks. Cheers.